So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together.
Okay, John, welcome back. I mean, we're still talking from before, but we have a separate episode here talking about the DSM related to OCD and anxiety disorders and what they did. If you're just tuning in because this is going to be appearing before the last episode, this is the second episode. The first episode, we talk more about the DSM globally, what is doing well, what is not doing well, some proposes of how maybe we could be doing things differently and problems. And this episode, we're going to be talking more specifically about OCD and maybe some about anxiety. So let me open up the field to you to talk about what your thinking is here.
Sure. So in the DSM-4, which again came out in 1994, and then the DSM-4 TR, which came out in 2000, and back, previously till about 1980, OCD was considered an anxiety disorder. It was clumped together with things like social phobia and specific phobias of like storms and dogs and water and stuff like that, and panic attacks and agoraphobia and PTSD a little bit later on. But until 2013, OCD was considered an anxiety disorder because people recognized OCD involves a lot of anxiety, and it does. In 2013, the DSM committee, they took OCD out of the anxiety disorders, and they created a new category called the obsessive compulsive and related disorders. And in that group is OCD as kind of the flagship. They invented hoarding disorder, which I think was a good move because hoarding used to be a part of OCD. And we know a lot of people who hoard, they don't have other symptoms of OCD. So they made a new diagnosis called hoarding disorder, which I have to give the DSM credit, based on science. Good call. That was one of the good things about DSM-5. That is absolutely a thing. Then they also clumped in body dysmorphic disorder, which used to be a somatoform disorder. So this is where the person has obsessions and compulsions about their physical appearance. My nose is too big and I check in the mirror all the time. They also lumped in trichotillomania, and they upped their game with the name. It's no longer trichotillomania, which is a horrible name. Now it's hair pulling disorder.
Oh, that's much better.
It's a little more descriptive,
yes.
Right? Why do you have hair pulling disorder? Because you pull your hair. Why do you pull your hair? Because you have hair pulling disorder. We talked about that in the other episode. So hair pulling disorder is OCD now, is obsessive compulsive related disorder. Skin picking disorder, which is basically same thing as trichotillomania, same thing as hair pulling, but it's picking your skin. And there might be one other that I might be forgetting, but those are the main ones in the OCD related disorders. And one of the things that was a problem for me, actually I've written lots of stuff as to why this whole thing is a problem for me. One of the things that's a problem for me is that why do you need to take OCD out of the anxiety disorders? For what it's worth, if we're going with DSM, OCD looks a lot more like social anxiety, looks a lot more like, phobias than it does like hoarding or hair pulling, right? And I know I'm getting to that part, but people with hair pulling, they compulsively pull out their hair. Yes, they do. And that's another problem. We were talking about mechanisms in the other episode. The mechanisms of OCD and the mechanisms of particularly hair pulling and skin picking are very different. So one way to look at these OCD related disorders is that they all involve compulsive something. And because they all involve compulsive repetitive behavior, whether it's checking, washing, hair pulling, hoarding, skin picking, whatever, they should be grouped together because on the surface, they all involve repetitive behaviors. Now, one issue with that is that like most of the DSM involves repetitive behaviors, right? Let's just take bulimia, right? Bulimia involves repetitively making yourself throw up. Is that OCD? No, it's not OCD. It's completely different. People don't go throw up from bulimia because they're worried about, germs, contamination, things like that. They have a body image problem usually, right? Lots of things have repetitive behaviors, but in particular, they chose these to group together. Let's take a look at OCD. In OCD, the compulsive rituals are based on this idea that if I wash my hands, for example, that's going to make me less anxious. And that's going to remove a threat. What's the threat coming from? The threat's coming from an obsessional thought that I'm contaminated. Yeah, so maybe I touched that doorknob over there, and maybe 30 other people touched it and they didn't wash their hands, and now their germs are on it, and now I can't stop thinking about that. But if I go and wash my hands, I'm going to feel better. And that's what people with OCD do, and that becomes more and more of a vicious cycle as it goes on. That's how OCD works. Trichotillomania, or I should use hair pulling disorder, the repetitive compulsive behavior is very different. People don't pull their hair or pick their skin because they're worried that something bad's going to happen, because they're trying to remove anxiety. Hair pulling and skin picking, there are no obsessional thoughts or fears. Hair pulling and skin picking are done because those behaviors, they might relieve some general stress or tension, but often they actually feel good to the person. And we know this because people report that they'll pull out their hair, they'll pick their skin, and then they'll bite on the hair, or they'll tickle their face with it, or they'll bite on the scab. And they'll say that they get some sort of satisfaction from these kinds of behaviors. I got to do it until it feels good. They feel every bit as distressed and anxious and guilty as a person with OCD does. Sure, that those are general experiences. But the mechanism is very different. There's not a fear that, oh, if I don't pull my hair, something bad's going to happen. If I don't pick my skin, something bad's going to happen. You don't see that like you do in OCD. And because of that, the treatment is very different. Exposure and response prevention, is arguably the best treatment for OCD for most people with OCD, not for everybody, but for most people with OCD. And that involves, hey, face your fears, don't do your rituals, and find out that you can get through it. Your anxiety, your fear doesn't come to pass. You can manage the distress. We don't do exposure for trichotillomania. What would we do exposure to? What's the fear that we would expose the person to? We do a variant of response prevention, but what we're actually doing in the treatment of let's say hair pulling is we're actually helping the person to make it less likely that they will pull their hair by changing around their environment. So if they're using hair clippers to pull their hair, right, or like tweezers or something, we hide those, right? Or we put tape over the mirror so they can't look so closely. So it's kind of the opposite of exposure. In helping people with hair pulling and skin picking, we help them to wear gloves so that they're, right. So it's harder for them to pick. In exposure and response prevention for OCD, we want to put them in a situation where they would do their ritual and help them to resist, but leaning into it. Here, what we're teaching them is, you can learn other ways of coping with that concern, with that urge to pull, by doing something else with your hands and by avoiding situations in which you do pull. Very different from the treatment of OCD. We think of hair pulling and skin picking as impulse control disorders. And if you look up the treatment for those, it's very different than a treatment for a fear-based problem like OCD. Okay, I said a lot. So yeah, thoughts.
So is that so much a problem? Well, and just to go back, just anybody that's jumping in this episode, the DSM is basically like the main book of clinical disorders in psychology. And it's how people look through and diagnose people based on certain symptoms. And our last episode, really recommend listening to, is what is the DSM? What is and how does it work? And what ways might not it be working well? And that brings me to my question here is that more so a problem of classification based on mechanism, meaning this OCD mechanism that you discuss is a different mechanism than the skin and hair picking mechanism.
Yeah.
So is it that we get rid of the disorder, or should OCD be separated from that one because the science based on the treatment that works and the mechanism of action is different? So there should be OCD, and then there should be whatever we want to impulse picking disorder, whatever you want to. I don't know what the best name for that is. Now, would that be a better system then, rather than just getting rid of the diagnoses?
Well, I think it would be better. So what happens is that like we get us in the OCD community, we get referrals for treatment for OCD. Oh, well, tell me about your obsessions and compulsions. Well, I don't really have obsessions. I just have a lot of compulsions. Oh, well, tell me about your compulsions. Well, I pulled my hair. Oh, well, actually, so you have a different problem. This is actually not OCD. Well, wait a minute. My psychiatrist told me I have OCD and that I need exposure and response prevention. So I do have OCD, and so, it confuses lots of people, and it's confused mental health professionals that these things are somehow, related. It confuses people and it confuses mental health professionals who don't understand the mechanisms. If you understand the mechanisms, it's not confusing. If you understand the mechanisms, you don't lose a lot of sleep over, what the DSM has done, because you're probably not too focused on it.
You're not following it.
You're not following it.
Yeah, you're not treating hair picking like OCD. You're not doing exposure for hair picking.
Right.
If you know the mechanisms.
And that's what we were talking about before, that it doesn't matter what we call it. If you call it an anxiety disorder, an OCD related disorder, an impulse control disorder, if you understand the mechanisms, you know what to do as a cognitive behavioral therapist. You know what to do because you understand the mechanisms. But the problem is that if we're going to have a DSM, and if we're going to group disorders based on science, at least get it right. And what the DSM folks have said, and there's a book that's actually written in 2011, 2012, basically saying, here's the rationale for what's going to happen with the OCD related disorders. They use I don't want to say bad science, because bad science isn't science. They basically said, well, OCD and trichotillomania and body dysmorphic disorder and hoarding, they all start around the same time. They all start in early adulthood. But wait a minute, what disorder doesn't start, right?
Yeah.
There's some, but most of them do.
Yeah, start in
right?
adolescence.
So that's a non-specific. So then they say, well, okay, but you know what? A lot of them have what's the other argument that goes with that? Oh, a lot of people who have these problems, they have comorbid anxiety and depression. Well, again, like who doesn't have comorbid anxiety and depression? That's no way to use science to fit disorders together. So then they say, well, they all respond to the SSRIs. So we should group them together based on biology. But again, first of all, the SSRIs they're antidepressants. So why isn't depression?
Yeah, that's what I'm saying. You're getting to throw depression in there.
Right. And nowadays, SSRIs are given for pretty much everything. Eating disorders, right? Anything and everything, SSRIs. So then they say, well, there are some studies of the brain that show that these folks have similar brain mechanisms. And my answer to that is just categorically false. I've reviewed the literature. There is very little in the literature to suggest that folks with OCD and trichotillomania have similar, brain dysfunctions, right? Well, but people with trichotillomania, they have first degree relatives who have OCD. Therefore, they, and if you look at the data, again, very little, like 4% of people with trichotillomania have a relative with OCD. Meanwhile, take a look at the anxiety disorders, panic attacks, social phobia, agoraphobia, specific phobias. It's like, 20, 30, 40% have of their relatives have OCD. So if you're going to use those kinds of arguments, right, that, there's a genetic basis because it runs in families. Well, the anxiety disorders are much more genetically related to OCD than, if that's even a thing, than are these other, trichotillomania and skin picking and even hoarding. So it's just wrong. And again, don't take my word for it. I've written lots of stuff on this. You can find it, online.
Yeah, and I can imagine people sitting here being like, why are they getting it so wrong? Why are they not? And I think one way, and listen, I'm not behind the scenes. I've never been on a committee, but basically kind of my understanding is that just like politics at the US government level, where there's what would be good and the right thing to do, and then there's all the politics around it that are making people make decisions based on factors that are outside of maybe what the truth is or what's right or something like that. You also have that going on with the DSM.
Yeah.
where there's like maybe the science is there, maybe the reality, but there's also a lot of politics going on that people need to navigate that are also, it's not just a science-based book. I mean, would you, I don't know if you would agree or disagree with that.
I would agree 100%. It's not, I mean, and if you get a copy of the DSM and you read the first several pages, the introduction to it, the preface to it, which most people don't read, it basically says, first of all, it says, we can't tell you the definition of a mental disorder. It basically says that it is hard to, if not impossible, to define a mental disorder, but we're going to have this whole book of like 500 of them, right? So they basically say, and they explain and you don't have to look too far to find information about how these committees are formed and who's on the committees and their ties to, I'm going to say big pharma. People listening might have a problem with that, but the ties are there. People have done research showing like way more than 50%. I think it's probably more closer to like 70% of people on the DSM committees have ties to the drug companies. And maybe that's just because most good, psychiatrists who understand diagnoses happen to also have ties to the drug companies. But it's not a great look for the book. And there's also politics. Like I said in the other episode, we've been living with schizophrenia, I think, as like a 1% prevalence rate in the community. If we toy with that based on science, politics, whatever, if we toy with those diagnostic criteria and we make it too high or too low, too different than what it is, there are societal ramifications for that, big time. And so, I teach a class at the University of North Carolina where we talk a lot about these kinds of issues. And I'm not blaming any one person or group of people, but this is just a societal thing that happens when we go kind of messing around with mental illness. It's just, it's a big issue.
Mm-hmm. And then also, I just want to flip to the other side. We're talking about like some potential bad reasons why things are going well, but there's also a lot of people that are trying to do their best here. I think,
no doubt. I think people are trying to do their best.
Yeah.
I give people the benefit of the doubt. I think people are trying to, I don't think anyone's trying to game the system or no one person is trying to do that. Now, make no mistake about it. There are entities that are definitely looking to, capitalize on things, very unfortunately. But I think that's bigger than one person or even one group of people. I think people want to do best. I don't think there's, I would hope that there are no mental health professionals who have evil intent.
Yeah. And there's a lot of people working in this that are just trying to help people and do the right thing and stuff like that. And of course, just like anything, there's forces and this, that, and the other, and things move along and hopefully progresses in the right direction.
Yeah. And so people are probably going to take what we're saying out of context also. And
well,
and he's blaming, whoever, but
No, that's not the case. It's just discussing the potential factors as to where the book came from, good, bad, pros, cons, influences. Right. And just like anything, a lot of things are always in development. Like even our field, we did some bad things in the past that wasn't so helpful, that we had science for, that was actually harmful, and we thought we were doing the right thing and stuff like that. And then you evolve and you change and the science grows. And that's also part of it too, is that the DSM is a growing, evolving process over time. And part of that is that you just can't expect it to be 100% right, but you need to have healthy criticism of these things in order to move things in the right direction. It's necessary for things to get better.
That's exactly right. And that's what we're trying to do. Healthy criticism, maybe a little snarky, but that gets people listening to podcasts, right?
Yeah. You want a little controversy.
You reminded me of something that I think is important to point out to listeners. So at the ABCT, Association for Behavioral and Cognitive Therapies conference about a month or so ago that Jason and I both were attending, they showed a screening of a documentary. It's called Conversion, and it's all about the move and then the eventual change in the DSM to get homosexuality out of the DSM. So up until DSM 3, right? Yeah, DSM 3 which came out in 1980. Before that, homosexuality was considered a mental disorder. And so we're talking in DSM 2, if you go, and find it, homosexuality, if you were gay, you had a mental disorder. And there was a lot of pressure being put on the APA to change that. But again, status quo, these things, they don't change easily. This documentary, Conversion, covers how that change started to take place. And a lot of it went down at that conference back in the early 70s, the association, then it was called AABT, Association for the Advancement of Behavior Therapy. But it's just a wonderfully done documentary on how some folks started to influence the field and get to question these long-held notions that being gay was a mental disorder, something that now, 50 years later, we wouldn't think twice about. Like that's ridiculous. Mm-hmm. But it took, an act of God and there were people who stood up to that and who resisted that. One psychiatrist in particular, I'm forgetting his name, for a long time spoke out against it. But fascinating movie, Conversion. Yeah. I think you can find it on YouTube, and I highly recommend it.
And the therapy harmed people.
Right. And that's the thing. So they were doing conversion therapy. The idea at that time was if you're gay, you have a mental disorder and you need to be converted to being straight. And so they would do behavioral therapies. This is certainly one of the darker moments for behavior therapy, but we need to understand the history of that to, to really understand what, behavior therapy is about, what our culture is about. But what they were doing was they were showing, gay images and shocking people. Right. And asking men to masturbate to pictures of women who were gay. Right now, we would think of that as being completely unethical. We would never do that in therapy, but that's what they were trying to do. And it didn't work. Yep. And it didn't work. And so little by little, people realized, why are we doing this? This is not it's not a problem. It's not a disorder.
And a problem with misdiagnosis too, being told that you have a disease when you don't have a disease.
Yeah.
And then I'm doing something wrong and people saying that you're doing something wrong because you're not getting better.
Yeah.
Right. And it's very dangerous and very, very damaging.
Yeah. We just, I think, we have a long way to go in terms, it would be nice to come back 500 years from now and see where things are with mental health and how we understand it and how we treat it. It was only a couple hundred years ago, we were boring holes in people's skulls to let the evil spirits out. And in some respects, how far have we come from that with some of the things that we're still doing, magnets and stuff like that. But I'd like to think that we're getting a little bit better, but it's a slow grind and there's a lot that we don't understand.
Mm-hmm. But I think this speaks to your mechanism approach, is that like in that case with conversion therapy, the idea is that there was no pathological mechanism.
That's right.
And if you know that there's no mechanism there, then there's nothing to treat.
Nothing to treat.
And That's so, right. And then the treatment was based on a non-mechanism. And so
these were people that were completely happy until they walked out into society. Mm-hmm. Right. It was society's problem. What a perfect example of problems with the DSM. It was society's problem. It wasn't the person's problem. Exactly. Yeah, it's fascinating.
Yeah. Because if there was a societal acceptance and people were allowed to love who they were allowed to love and all that, it wouldn't have been a problem at all.
That's right.
Yeah.
That's right. Which is what we have now in most sectors of society. Not in all.
Not in all. Yeah. Yeah. It's definitely a problem still in a lot of areas. So looping back to the anxiety disorders, was there anything else in the DSM that they did or that you think should be? Is it mostly this creating this OCD category and clumping two things? So basically, the idea here is just to sum that part up is that OCD, if you're going to put it with something, probably more closely relates to an anxiety disorder than with the hair and skin picking disorders. So you could argue that there should be anxiety disorder bucket, an OCD bucket, and then having the picking stuff in a different bucket. But if you're going to put it in a bucket, it's more closely related to the anxiety bucket than it is the picking bucket, right?
Yeah, the OCD is much more in the anxiety bucket. The picking bucket is more like impulse control. Like, this feels really good and I can't resist doing it. The OCD bucket is, I'm really afraid and I got to do this to manage my fear.
Yes.
Yeah.
And so maybe it should be its own bucket, I guess, depending on the mechanism of how different the OCD mechanism is compared to the mechanism for anxiety disorders.
Yeah.
And also treatment response too, I would imagine is important too, because we know like OCD for the most part, exposure is going to be the most effective, where some of the other anxiety disorders, exposure could be very effective, but we also have other effective, like cognitive, treatments and stuff like that, which OCD might not stick to, as well.
Yeah. Well, the mechanism of change is cognitive. We want people to change their thinking patterns. Mm-hmm. You can do that with like cognitive therapy, cognitive restructuring. You can do that with exposure therapy. Exposure therapy is the best form of cognitive therapy. What does exposure therapy do? It teaches people new information. It changes their cognitions. So you're still, yes, people with OCD respond for the most part better to exposure than they will to cognitive therapy. But that's only because they can hijack cognitive therapy and turn it into a ritual.
Yes.
Right. But the idea of cognitive therapy and exposure therapy for all these anxiety problems is basically the same. But one thing that we haven't touched on is OCD a thing?
Yeah.
Right. And is OCD a thing?
Okay.
Right. So we've already taken hoarding out of OCD. Hoarding used to be OCD. But, with OCD is so heterogeneous, is it one thing? 500 years from now? Well, right. Maybe it won't be. How many DSMs, is that from now? Mm-hmm. But yeah, is the ordering and arranging version of OCD, is that the same as the people that have the thoughts about like, what if I murder someone I love? Right. I don't think so. I think the mechanisms are pretty similar, but I've worked with enough people with both of those to say, these really feel very different.
Mm-hmm.
Yeah.
What would you propose is the different mechanism between the two if you gotten that far with your like self-analysis?
Yeah, I think that the people who have the kind of everything has to be arranged just right and ordering, I think many of them, not all of them, many of them have this kind of not just right experience. I need to feel just right in order to go on. And I can't stand that feeling of not just right. Something's off. Something's not balanced. The left shoe is tied tighter than the right shoe, or the books aren't arranged the right way, or the picture is tilted the wrong way. That kind of almost perfectionistic, kind of not just right. And I think that ultimately is different than I have these intrusive thoughts about harming, my partner, and I love them very much, and I would never do anything to them, but I can't stop thinking about them, or thinking about harming them. And so I hide all the knives and I say prayers a million times and all this kind of thing. I think that that's different. We call it all OCD right now, but I think that those things are different. And actually, that's some of the work that we're doing in our lab. We're doing some research to look at how where do those differences play out? What's different about them? Do those differences really matter? Do they matter in terms of treatment and all that? Those are open questions.
And then a lot of people also have multiple, like they could have both.
Yes, exactly. Yeah. They can have both. So at some level, they're co-occurring a lot. What does that say? Great point. Yeah. Again, lots of stuff that we don't understand. But again, I think it gets back to, does it matter what we call it? So they all have OCD, they all have OCD, whatever that is. But really what I'm saying is that what's more important than kind of labeling them, throwing them into the OCD category, is understanding the mechanism. So this person has the not just right experiences, and that's what they're trying to avoid. The other person has these intrusive, terrible thoughts, and that's what they're trying to avoid. The third person has fears of germs and contamination, and that looks a lot more like what we would call a phobia, right? Phobia of illness or stuff like that. It's not important what we call it. What's important is that we understand it at that mechanistic level if we're going to do good therapy that we know works. And again, I'm talking about that broad umbrella of cognitive behavioral therapy.
Mm-hmm. Yeah. And, I keep bumping into my head, like, doesn't matter as much if the training is there. So if everybody's trained in effective treatment and they know the mechanisms, doesn't matter if the diagnosis is based on the mechanisms. But then it's like a circular thinking that keeps going in my head, is that if the diagnoses were based on the mechanisms, more people would learn would learn the mechanism. So maybe that's the way that we better or just listen to all my podcast episodes, right? That's another
People
way
should definitely do that. So there have been attempts to try to be more mechanistic. And the NIMH, National Institute of Mental Health, about 10, 15 years ago or so, they came out with what they call the RDoC, which is the Research Domain Criteria. I think I got that right. Research domain criteria. And again, you can go online and check this out. They were trying to get away from the diagnoses. And actually the American Psychiatric Association had a little bit of a hard time with the NIMH because those two organizations, tend to be fairly well aligned. They had a little bit of a hard time that the NIMH was saying, we can do better than DSM. But the idea there was, let's look at all these different, primarily biological mechanisms, and let's try to, instead of thinking about disorders, let's try to think about who's high and who's low on these different mechanisms. And I think that's a little bit of a step in the right direction, except that it was all biology and it was all stuff that unfortunately didn't have a lot of good reliability and validity, and the research just isn't there to support biological models of these problems. We've seen, last summer we saw this article come out basically debunking the serotonin model of depression that antidepressants are based on, basically saying there's nothing to that model. And then just recently we had another article come out basically talking about the problems with neuroimaging research, and that we really can't trust that nearly as much as lots of folks, would like to. Or, we look at these sexy pictures of things lighting up in the brain, but we wonder about how much that's really telling us about, mental illness. And so, we start to wonder about, we need to look beyond biology. I mean, you talk to me, I've thought that for a long time. Mm-hmm. I'm a cognitive behavioral psychologist, and I have my biases too. But if someone showed me, hey, do a brain scan, and everyone who looks like this under the brain scan, they have OCD, and there's a pretty high, better than chance rate of being able to diagnose them based on this. Or here's this genetic test, or here's this blood test, and you can tell if someone has OCD. I'm a scientist over, more than I'm a cognitive behaviorist. Show me the data.
Yeah, you'll do it.
I'll change my tune, and I'll say, oh, OCD is a genetic, thing, and we've got the data to prove it. We don't have that. We don't have that for any mental disorder.
And that might, and you need a lot of, because, there's the interaction model too, right? Biology times environment. So it could be a biological predisposition in the genes, plus these mechanisms that work on that genetic predisposition, which then create it. So even if they found biological underpinnings, it doesn't mean it's going to be the whole story. It
Society,
could be part of the story.
Culture. That's exactly right. People make decisions. That's the thing about studying psychology. People make their own decisions. People behave and all that, and it makes it confusing. We're not just, viruses and stuff and atoms and stuff like that. It doesn't work that way.
Yeah. It's
fascinating, but it's confusing.
Well, one thing I say to my trainees is that it's amazing that we go to years of schooling to get a blueprint about how humans operate, that we're not born like with this knowledge, that there's whole degrees to study us on how we actually function, because we don't know. We have to research it.
That's right.
And I find that mind-blowing that we have you and all of these people out there, that your full job, well, not full job, but a big part of your job is researching how humans operate, because we just don't know without it.
Yeah.
Or we make assumptions. Yeah.
We make assumptions. And I think, clearly, like, I have a pretty cynical view about all this stuff. And it's because I am in that world and I see what's out there. And I look at the state of our knowledge, and it's really easy to be cynical that we're not boring holes in people's heads, thank God, anymore. We've come a long way from that. And we do have good therapies for, again, OCD, anxiety, right? We do have good therapies for that, but they don't help everybody by a long shot. And we've got a long way to go. We've got a long way to go.
Before I let you go, any final thoughts or words you want to say before we sign off?
Well, we've covered in these two, in these two episodes, we've covered covered a lot of territory, and we've covered some territory that's a lot of hot button issues here, right? Because a lot of people are like, well, I have my diagnosis, and don't tell me that it doesn't exist. And so I just want to reiterate that we're talking about on a very scientific level. We're talking about the way that we can, and you put it really well, the way that we can, I guess, constructively criticize what's out there. And that's how we move the field ahead. And so to people that are going through problems like OCD, these are very real problems. They are very real, and nothing that we're talking about should be taken any less. They require professional evaluation, professional treatment. There's the field of psychology and psychiatry and all these mental health fields, thousands and thousands of people in the United States alone that all have these degrees that are working to help people. So these are real things. These are real problems. I think that where the criticism comes in is that the DSM wants to label them in a certain way that is problematic, that has certain logical and scientific problems. And I think that's what we're talking about. So I don't want anyone to get the wrong idea that we're saying that these problems, are that they don't exist and that we're poo-pooing them, or that John Abramowitz doesn't think that, these disorders exist, because that's not what we're saying at all. I think the point is that science advances by critiquing the status quo, by thinking critically about it in a healthy way to try to make it better, so that we can understand the things that people are going through, because they are real things and they are extremely, distressing and interfering in people's lives. And I just think I want to make sure that that's clear.
Mm-hmm. And also that it's not that there's zero utility in the DSM. The DSM is actually extremely useful, and it has a lot of benefits, and it's near the best that we might have now. But the question is, how can we make it a better utility and make it even better? So don't throw out the book, but how do we make the 6 better than the 5? Well, John, thank you so much for coming on again and spending more time with us. And it's always a great conversation, and I really enjoyed it. Thank you.
You bet, Jason. It's my pleasure. Thanks for having me back.